So really warm welcome everyone. My name's Kate. I'm part of the Visits Collective team and I'm here with Gwenor. And this is a visit, as all of you know, about reducing wait times in urology. I'm really excited to have you all here. I hope you're all not too hot. I know that for lots of people today working from home and offices, they've been melting. So I hope you're all doing all right. And I'm just going to share my screen very briefly. And just let you know what we're going to cover in the next little while that we've got today. So a couple of things to say about how we'll be using Zoom today. Some of you I know will be dialing in from offices or from busy places. So if you've got background noise, feel free to be muted, just so that we can all hear each other and hear our speakers. We really encourage you to have your cameras on if that feels possible for you. We know it won't be possible for all of you, or you might not want to, but particularly when we're in smaller breakout rooms discussions, which we'll do a couple of today, it'd be lovely to see your faces and so you can meet each other. And as I mentioned already, you can put your organisation alongside your name by going to the top right of your photo and clicking the three dots. And this is a Q community event that's open to lots of people who are Q members or not. And I just wanted to invite Katie to say a little bit about the Q community and to say a bit more about the benefit of becoming a Q member. Katie, over to you.
Hi everyone. Yes, as Kate says, the Q community is available for anyone to join. So we are a group of more than 6,000 people, all with an interest in quality improvement or working in quality improvement. So it's an opportunity, and I know many of you are members, but for anyone who isn't, then we have things like this and other workshops going on, an opportunity for you to really learn and grow and share ideas. So the idea is that we can scale and spread what is working in one place to another. So it's really flexible, but yeah, it's free to join. And I think on the next slide there might be a QR code. Great. So yeah, please feel free to get your phones out and snap that, and then and do join us. But we have all sorts of different things going on, like lots of different special interest groups. So if you have a particular area that you are focused on, then you could join one of those groups. Yeah, we'd love to have you join us. Thank you.
Thanks, Katie. And if there are Q members here, it'd be lovely to hear in the chat if there's particular groups or kind of connections that you've made through being a Q member, for other people who aren't Q members to hear a bit more about that. So feel free to share if there's something you want to share around what it's like being a Q member. And just a little reminder of what we're going to do today. So we're going to hear from STS My Healthcare, who are going to talk to us about how they've taken steps to improve patient experience and reduce wait times in the urology pathways. And we've got Mani Desi and Asad Abaden, welcome both of you, who are going to talk about their roles in that work and their experiences of the transformation they've undertaken. We're going to hear a bit about patient experience and the benefits that patients have experienced through taking part in that process. And you're also going to have the opportunity to reflect on how this approach applies to your own work. And quick reminder of timings. So we're going to do some introductions shortly. You're going to have the chance to say hello to each other. We'll then hear from Mani and Asad, and there'll be a chance for you to ask questions as well. And then we'll finish with some more breakout rooms and a chance for you to think about what you're taking away from this session before we close at 5:30. So one of the things we always hear during these visits is how much people enjoy connecting with each other and hearing a little bit more about each other's work. So we're going to have the opportunity to do that now. We're going to go into some breakout rooms. It's absolutely fine if for any reason you aren't in a position where you can join a breakout room right now, that's okay. Feel free to just stay in the main room, but we're going to invite you to go into breakout rooms and to introduce yourselves to each other, to share your name, your role and your organisation, and to share what's brought you to this visit. What are you interested in learning about, or what's kind of piquing your curiosity? And yeah, we'll give you just under 10 minutes for this, and then we'll come back together. Welcome back, everyone. I hope that was a nice opportunity to connect with each other and meet some other people who are here and interested in this event. We're going to move on now to hearing from our speakers. So we're really lucky to have South Doc Services here with us. We've got Mani Desi and Asad Abiden who are here. I'm going to hand over to Mani in a moment. So Mani is Chief Transformation Officer for South Doc Services and SDS My Healthcare. And Mani leads on the design and delivery of innovative community services, and so has been playing a really key role in the reducing weights urology pathway work. So Mani, I'll hand over to you. I'm going to spotlight you, and I know you're going to bring in Asad later on as well. And yeah, over to you to tell us a little bit more about this work.
Cheers, Kate. Thank you. Hi, everyone. Hopefully the first goal is successful. Can you see my slides? Great.
We can.
Fantastic. So thank you so much for this opportunity to share this work wider. And myself and my colleague Asad are just going to go through some of the key learning aspects. And I just want to start off by saying a big thanks to Health Foundation, the Q Lab, because without them we wouldn't be successfully doing this work. And hopefully as we go through, we can all sort of share some of that, what would probably be some learning around challenges, but also some optimism about the future. And I think that's what we're about. So yeah, I'll probably kick off, and then my colleague Asad will share some more information. So from our perspective, our focus is around transforming urology. So let's have a look at why we're doing that. In our organisation, we have done a number of transformative long-term condition work, such as dermatology, renal, like many others have, which is fantastic. However, we really wanted to stretch ourselves as part of the work that we've been doing, and we had a look at what are some of the services that have got some challenges, but also would be probably more traditional to secondary care type work. So we chose on urology. The teams in secondary care are working really hard around supporting those elements, but we all know that during and post-COVID, there is a lot of pressure on those weights that are still being needed to be improved. So from our perspective, we spoke to a number of stakeholders. So that includes patients, our primary care team, but also secondary care consultants. And there was no doubt there was a great deal of enthusiasm, passion to change that pathway, work in a different way, and try to make those services work better for everyone, so that there were reduced delays for patients, that there was more appropriate demand for hospitals, and there was more local support in that work. And we all know now that there's a great push around delivering care in the community, so-called left shift, but we also know that's been talked about for the last 20, 30 years. So how do we make that a reality? And that's why we chose what we felt quite a challenging area of urology to try to see how we transform that work. So I think from what we've learned in the last sort of 10 years that we've worked in this arena is that there is a grey area in between primary care and secondary and community care too, where because that gap is not really robustly filled or supported, there's some negative impact on patients. So that results in work coming from primary care that is going to secondary care that probably could be dealt with, which we now know, in a primary care setting, which could have been avoided, which actually helps the patients to be supported more locally, more rapidly, and again, avoid that pressure that secondary care are feeling now and probably for the last few years. So that grey area also has issues whereby there's probably areas that the secondary care want to almost not quite discharge, but sort of send back to primary care, but there really isn't the skills and capacity to do that. So all of that leads to a lot of variation, a lot of inefficiency, and poor patient care. So really we thought, actually, is there a way, as we've done in other long-term conditions, really to support that grey area in a much more robust manner? Before I go into how we did that, just a bit of background in terms of our organisation. So South Doc Services is a GP collaborative. We support areas such as Urgent Treatment Centre. The GP Federation that we support looks at transforming pathways, trying new ways of working, and really trying to smooth those elements that lots of different stakeholders are telling us that they want to change. In terms of size, so we support 65 practices, 9 primary care networks, and a population of 430,000. But my main message around what we do is really what some people call disruptive innovation. We are definitely not everyone's cup of tea, if I'm honest, because we are challenging in what we do, and it does really start to question what we've probably worked in a traditional way, which we all know can feel a little bit, well, why would we want to do that? But hopefully we do that in a supportive and a safe way, because we genuinely appreciate that a lot of those results are because of how traditional systems and levers and incentives are designed, and it's nobody's fault. And what we have the really lucky opportunity with people like QLab is to try different things, and really try and experiment with those different things, and learn from that. So that's the sort of approach that we've taken. I'm going to hand over to Asa to talk about what we've actually done within our urology service and some of the details of the how.
Next slide, please. So this slide summarizes the mechanics of the clinic. So we have a referral form with pathways for all the common, what's called core or general urology conditions, such as men and women with urinary symptoms, recurrent urinary tract infections, erectile dysfunction, blood in the urine on dipstick testing, which does not fall within what's called a rapid access pathway to hospital. So the GPs would refer to the service using the referral form. I would always insist on a virtual review of the referral to begin with, partly because occasionally we were still seeing referrals which were inappropriate, which would fall in the exclusions. So these are patients who would need to go to hospital, they essentially had suspected urological cancer and therefore were inappropriate for community care. But more importantly, this would allow myself, and subsequently we've got a second consultant who joined the service about a year ago, to suggest pre-treatment that the GP could start with. This would be medical treatment with tablets, looking at as a trial for the patient, to try and help their symptoms before they came to see me or my colleague in clinic. So all the patients would have a face-to-face appointment. We would see this patient, take a clinical history, examine the patient, and have access to high-end ultrasound scanning, and also to what's called disposable flexible cystoscopy. So that is an endoscopy of the urinary tract, of the bladder and the water pipe, which we could do in the primary care setting. So this clinic is based in a large GP surgery within South Birmingham, and is based in a purpose-built procedure room with an attached consultation office. Now, the outcomes of that face-to-face consultation and the appropriate investigations would be, firstly, ruling out serious conditions and providing the patient with appropriate reassurance. So many of the patients are looking to know that, for example, they haven't got anything serious like cancer. Number two would be to provide a management plan based on conservative measures and medical treatment. So tablets to try and help their symptoms. One of the outcomes would be to provide the GP with a diagnosis and a management plan which they could continue with. Clearly, somewhat the patients would need to be followed up And our new to follow-up ratio is 1 to 1.2, which is again very, very attractive. Next slide, please. So these are just some photographs of the setup. So we've got a large procedure room. This is a top-end ultrasound machine supported by an ultrasonographer, an ultrasound scanning technician, and at the top and the bottom right, we've got a photograph of a disposable cystoscope and the digital monitor. So that is to actually visualize, the water pipe and the bladder. And we normally use that for patients who have suspected scarring of the water pipe, have difficulty peeing, or they may have potentially, blood in the urine, but they don't fall in under what's called a rapid access referral pathway. The clinic is also supported by a healthcare support worker. Next slide, please. So the idea of the clinic is to try and utilize the one-stop approach as much as possible. Over the last 2 years or so, we've seen over 1,000 patients from over 50 practices within our federation, within our service, and our referral rate to secondary care is less than 10%. So over 90% of patients are sorted out within primary care. Now, clearly, the patients we're seeing are selected in that we are dealing with what's called bread and butter, or what's called core urology. Now, that does represent the large proportion of urology, which is uncomplicated, and needs to be sorted and can be sorted out in the community. This is clearly has the effect of making sure the patients who do go to secondary care are those whose conditions definitely need hospitals. That obviously frees up capacity in hospital for patients to be, appropriately managed there, and also allows, a better experience for our patients who are managed in primary care. Next slide, please. So this is an example of patient feedback. Thomas, a 38-year-old male, and what he tells us is the whole experience was positive. He was looked after throughout the process and was felt listened to by the clinicians. In the end, everything was resolved, which was great. The wait for the appointment was less than 2 months. It was really good, as I'd heard. It could be much longer elsewhere, even for urgent cases. The location was convenient, only 15 minutes away from home, easy to travel by public transport. Overall, my experience was very good with no issues. Next slide, please. So we carried out, as you'd expect, a patient feedback exercise. We asked 6 questions. And as you can see, overall, the responses, the feedback were overwhelmingly positive. So we asked, were the patients satisfied with the service they received from the urology consultant? How convenient was the appointment that you were offered? Were you involved and informed in the decisions about your care? Did you have enough time to discuss your condition with the clinician? If you had an important question, did you get the answers that you could understand? And would you recommend the service to families and friends? So these are clearly, key patient feedback areas. I mean, very much our um, approach has been to give the patients adequate time to, not only be properly assessed, but to allow us to explore their concerns, their anxieties, and to make sure that we can answer them as well as possible. And that leads to high patient satisfaction, and it reduces the risk for repeated follow-up. Next slide, please. So these are some samples of free text feedback that we received. So there is a question from the audience. The consultation is taken by consultants. So I am a urology consultant, and there's another colleague of mine. So these are consultants who are seeing the patients. Feedback comments. Our approach was very friendly, welcoming, not intimidating. I think the location in a primary care is less intimidating than hospitals. Its ease of access, parking, etc., all helps to make a more sort of less anxiety eliciting experience. The second patient says, seen in the community setting, it was relaxed and friendly, felt at ease. The consultant and the team were approachable and considerate. And as I've just mentioned, patient number 3 says, good to have contact with a urologist without having to go to hospital and wait a long time for the appointment. And lastly, very helpful, thorough and informative, and all at my local surgery. Excellent. So the theme you're seeing is that people feel more comfortable being seen and assessed by an expert, a specialist, but in the community. There are some practical advantages, such as, you don't have to take the morning or afternoon off from work. You can have free parking. It's easier to get to, but also very much people are used to attending their GP surgery, and it's less of a sort of formal setting.
I said we'll come to the questions at the end. We're going to have a bit of time for Q&A, so feel free to carry on. And I'll feed these questions back at the end. Yeah, go for it.
Perfect. Next slide, please. Right.
So
over to you, Manny.
Yeah, thanks, Asa. So yes, so thanks, Asa, for talking through, at quite a high level in terms of the service. Clearly, we are happy to take more detail and Q&A, but I just want to share some learning and next steps from our perspective. So there's no doubt that from the way that we've been working, and as we alluded to in the beginning, it is reducing that initial variation, because some of the work that Asad and colleagues are doing in terms of that virtual review, we have full access to the records. So we see the history of that patient. And then when they go back with that specialist advice and knowledge, it really, is able to do really holistic information, holistic support, and where possible, direct them, say, look, actually, you can deal with this in primary care, give them that confidence, that reassurance, because sometimes even that safety net, knowing that service is there, means that primary care feel more comfortable in trying more things. And it's without over-egging it, just seeing them early in the pathway clearly has benefits in terms of reducing those delays, reducing acuity, which then obviously reduces potential unnecessary hospital admissions, and also that anxiety that Asad has mentioned, because the sooner you know that it's something not serious, then all the better for that patient. And if it is, then trying to get that support as quick as possible. So in terms of our experience, working with the stakeholders, that includes the clinicians from primary care and secondary care, the patients, there is no doubt that there's a burning, platform, but also a burning ambition, to be honest, about how do we transform those urology services, because we've seen the benefits of reducing those unnecessary waits, reducing the patient delays, as Asad mentioned, easier patient travel and parking, and all of that. And we've got to be mindful that funding is very difficult and tight. These are reducing the costs. It's a very cost-effective way of delivering that service. We are reducing the demand, as I said, and reducing those delays. So it's a real big win-win. Now, from our perspective, we really want to spread and adopt that learning to others. Obviously within urology, but actually, to be honest, part of the reason why we chose urology, as we mentioned, our view is if you could crack urology being delivered in a community setting, really, most specialties could be run that way. Obviously, there'll be some tweaks and modifications, but it really sends a message that the left shift, care closer to home, I think of all the jargons, out of hospital, whatever the lingo is for the last 20, 30 years, here's, an evidence-based way of successfully doing that. And what we really want to happen is for, commissioners to really buy into some of the pathways and commission differently and help the whole system to work in a way that it really is aligned and tuned. And it might sound, overly optimistic, but I do think it is in our gift. It's about being brave. It's about understanding that we do need to look at the different levers, and we do need to work across, all the different stakeholders, patients, service users. But it is possible. I think that's the most important message. It is definitely possible if we can break it down to those constituents and make a huge impact within urology, and as I say, wider than that. So from our perspective, that approach in the new ways of working, we really do minimize the number of, face-to-face consultations by doing that early work, trying to, support other entities first, and then it being appropriate when needed. As we've said, a lot of that can be managed in the community. We know that we all want to do that work out of hospital, and it's about moving that forward. I think the other key final thing to talk about is that a lot of the success of this is the confidence that the clinical team and the non-clinical team have found by running these services in these settings, having that reduced administration burden, because we do run everything within the existing primary care system. We've not bought a brand new IT system or something really that no one else can replicate. These are all things that are already in the ingredients to bake the cake. The toughest thing is about working on those relationships, those changes, the pathways. But again, that is something that, is eminently possible. So, we mentioned integrated working. By having these staff working within the same clinical records, being able to message, the primary care clinicians very quickly, has built a lot of integration into that work, which is something that we all want to do. And also, we are very conscious about capacity and the staff. So we're trying to really make, Assad and the team, as effective as possible with their limited time. So they're going to say, look, actually, it really is a powerful way of delivering these things in a different way. So that's it from myself and Assad. If there's anything else that Assad wants to add before we hand over to Kate.
Assad, anything else from you?
I'm fine. No, that's fine.
Brilliant. Thank you both so much. We've got lots of questions in the chat, so I'm just going to feed these in. And then once I've gone through them, if there's other questions, please feel free, everyone, to come off mute and to ask them out loud. It's always nice to hear your voices. So the first question from Samantha. Samantha's asking, what data was gathered other than the type of referral being submitted before coming to the solution of this pathway? How did your RTT numbers change?
We don't necessarily work on RTT figures, but that's obviously a hospital-based element that we won't have access to. But in terms of what we've engaged with, is obviously our primary care clinicians who would have experienced the current service pathway. We've also met with various consultants, both within this system and outside the system, to hear about, the way that they operate and how they want to work differently. So that's how we operated, and obviously the patient feedback that we've collected.
Thanks, Manny. And Samantha, I know you can't, you can hear us, but we can't hear you. So I'm sorry that I can't invite you to, I know you've got a few more questions, but I'll feed them in shortly. Christine's asking, was there a change required in the workforce and clinical teams' ways of working? And what did that look like?
Absolutely. So, I mean, essentially, my sort of day job, if you like, is a secondary care consultant, and this is very much a pilot of firstly coming and working in a primary care setting, and bringing many of the diagnostics that we have, from secondary care into primary care. So, for example, obviously, high-end ultrasound. I mean, ultrasound scanning is not a new thing in primary care. That's pretty common, but cystoscopy isn't. That's quite a new thing for primary care. And but otherwise, it's really trying to take parts of what we do in hospital, which can be easily brought into primary care, such as consultation, medical management, assessment, and so on, for the benefit of the system as a whole. Because certainly, what Lord Darcy has picked up was that, productivity in secondary care has been going down. More resources have gone into secondary care, but we're actually doing less, as secondary care health professionals with greater productivity. That's not really a formula for future success in constrained with constrained resources moving forwards. So I hope that answers the question.
Thank you, Asad. And Sharon's asking, how long was each consultation?
Yeah.
And was that always done by the consultant, or did specialist nurse lead on any of those elements?
Yeah. So a new consultation is 30 minutes, but that's not just seeing the patient, examining the patient, but also doing an ultrasound scan. I wouldn't do a cystoscopy at the same visit. Firstly, our rate of cystoscopy is quite low. It's not, most people will only need an ultrasound scan. So essentially, so the 30 minutes gives you taking a history, examining the patient, doing a scan, coming up with a management plan, explaining it to the patient. As you can see from some of the examples of feedback, giving the patient adequate time to understand, take on the the outcome, as it were, and also give them the opportunity to ask questions, making sure they're clear about it, making sure they agree with what you're explaining to them. That's really important to make sure you have high satisfaction, rather than having a kind of in-out, rapid fire kind of setup, which you have in many secondary care clinics, which are overbooked, and patients don't get the opportunity to really understand their problem and understand the plan.
Thank you. And there's a couple of questions from Samantha. Samantha's asking about how business intelligence supported with data, and also what transformation tools did you use to lead to this solution?
Yep, I'll answer that one. So in terms of transformation, we've tried to work on the premise of let's gather as much information from the current stakeholders involved. So that includes the clinicians, as I said, from primary care, in terms of what was happening in there, and the conversations with the consultants, and also trying to ascertain what the feedback's been from the patients and their experience and so forth. And we did gather some of the waiting times that was available from the hospital, in terms of the wait there and how long that was taking, and the numbers that was running into, I think at that time was I think several thousand in terms of what was waiting. Then obviously the different stages of those. We could I'll check with post the webinar with our team, because we work in primary care and we have quite a limited data team, but we could have a look at, in terms of the timescales of people we're taking from the existing time to how long we take. So we could have a look at that and definitely share that wider, so people get an understanding of those elements. And in terms of transformation, we did work on that plan, do, study, act. So we started off with a very small scale test first, just starting with looking at some of the information that was presented by primary care to start with, and seeing how much we could go back with some of the special advice. Then we added the sort of next stage, face to face. Then we added the next stage of diagnosis. So each stage we added the different components and then tested to see what was working and what was working well, before then we continue to the next step.
Thanks, Manny. Jamie, I don't want to put you on the spot, but I wonder if you want to come off mute and share your question out loud. I know you had a question about how often the clinic runs. Do you want to share that out loud? It's always nice to hear other people's voices and not just mine.
Hi, I can do, yeah, that's absolutely fine.
Jamie.
Thank you. Great presentation, really interesting model, and lots to learn from you guys, I think. So yeah, I may have missed it at the start because I joined a little bit late into the presentation, but I'm just wondering the scale of the project that you're doing. So are you taking referrals from multiple GPs, primary care network practices at the moment? Are you anticipating to scale even further? And how, just practical things like how often does the clinic run? How many appointments do you have within that clinic? Yeah.
Sure. Okay, we'll try all of those.
Thank you.
Thanks, Jamie, and really good to hear, as you say, a voice. So yeah, from our perspective, going back to the approach, we did start with one GP practice first, again to test out the process, and then slowly we expanded to more practices and more primary care networks. So we've ended up supporting 50 practices within our organisation, covering several primary care networks. So really, there's not a restriction in terms, except for one, which is the budget. And the budget, this work has actually been, sounds like a plug and a sales plug. Thank you to the Health Foundation for their sponsors who actually funded this work. But obviously that is limited. So a lot of that was constrained about those elements. So at the moment we run a day a week. We have 2 sessions on those days, doing various elements. So that is the constraint that we've got at the moment. The project itself was time limited and is coming to a close now. Ran it for a couple of years as a proof of concept, but we are working with commissioners and sharing that data and talking about trying to get them to think differently. So it was a proof of concept, basically trying to say to them, look, this is the art of the possible in a very different arena. As Asad and the fantastic colleagues have shown, that so much can be done in a primary care setting, and that left shift, is definitely possible. So did that answer everything?
It did. I think that's brilliant. I have got an add-on question following on what you've said, if that's okay, and then I'll let you go back to the chat. But from an income point of view, there has this generated income from a primary care perspective, and has income moved from coming into the hospital trusts through into primary care, because that could be a sticking point for other systems, I guess.
Yeah, that's a really good point. So there's no income for the practice in terms of that element, because this is, I mean, they don't get paid income for the work that's done in a trust anyway. So this is almost a parallel alternative pathway to what is already existing out there. And in terms of the future and hospital, the goal is, as we all know, to try to find that happy balance that we can look to try and move some of that resource from outside hospital into primary care, but also not destabilizing the hospital and how that works, and also making sure that the resources are in the same net funding envelope, because there's no extra funding. And I guess that's the conversations that we want to have with the different stakeholders. Say, look, there is potential efficiency savings by doing things differently, because they've told us that, and they're keen to do that. But we also know it's a very difficult thing to do because of everything that we've talked about.
I think I just want to add to that as somebody who obviously works mainly in secondary care, but has obviously been involved with working in primary care. I think it's about looking at the NHS as a whole, and having work done in an appropriate setting. So there's obviously things that can only be done in secondary care, be they emergencies, be they within my specialty, cancer work, or be it patients who need operations, patients who have you know, large prostates, kidney stones, etc., etc. But there's a lot of work which does not need to be done in secondary care, and which I think we do badly in secondary care. So things like patients who may have an overactive bladder, or women who have, or men who have recurrent urinary infections. You know, they need investigations, they need assessment, and they need medical treatment. That covers a huge amount, but that work is actually, firstly, it's not done very well in secondary care, and secondly, its inappropriate presence in secondary care is making the rest of the secondary care's activity inefficient. So patients who should be seen within 1 or 2 weeks are waiting for 3 months just to see a consultant, to have a chat, to have a consultation about an operation. Well, if we make more capacity in secondary care for what only they can do, you know, it's a win-win situation basically, where you have better outcomes for patients in primary care, better levels of service, better satisfaction, but also better satisfaction for patients who need to go to secondary care because they need complex operations. And that is an important minority of the work that my specialty does. I hope that tries to give you a more of an overall view of the health service.
Thank you so much, both. Tracy, would you like to come off mute? I know you had a couple of questions. If for any reason you'd like me to say them on your behalf, I can, but just wanted to invite you to come in.
No, sure. I think, to be fair, that was they're sort of follow-ons from the last one, because I think as a clinician we often define and are able to describe a much better way of doing things, and that's around, you know, earlier diagnosis and communication with our patients. And the frustration is the money element. And so I think it was sort of, I was interested in, if this was rolled out, it's accepted as, you know, benefits are great, patients like it, efficient, timely, etc. Would there be an impact, do you think, on the stability of the hospital team? And I think particularly in the Isle of Man, we have an issue with that, because we often have very small teams and we're setting up wellbeing partnerships across the island and thinking of doing very similar things. But actually the impact on one consultant or one specialist nurse, for example, it's quite a challenge. So I just wondered if you felt there would be an impact on the hospital team if this success was rolled out.
I mean, yeah, go on.
Good. I was going to say, I think this is probably what we've tried to really focus on, Tracy, in that. But your follow-up question about, you know, the communication between the acute and primary care clinicians, is it one team? That's the whole point. We're trying to make out that it is one team, it is one pathway, and how do we get to that point so that it's not a case of, if you do something in this setting, it's not connected and part of the pathway for the secondary care setting. So that's how we really look at it across that whole journey. And we know it's not easy, we know it's not, you know, but that's the only way that we can actually make those finances work. So it's not siloed pieces in step one and then step two. It's all part of that same pathway, but looking at where do we spend that limited funding and, you know, in the correct part of that pathway.
So, I mean, from my point of view, I don't see this as a primary care versus secondary care issue. It's very much a people who currently do the work in secondary care come out and do it in primary care. But actually, so if I look at my specialty, in order for urologists not to be destabilized, you don't want a situation where you take a particular consultant and just say you just work in primary care and have nothing to do with secondary care, because that will destabilize in terms of their competence, in terms of you know, that they will lose skills. Are you with me? So really, it's about taking, you know, consultants, nurses, therapists, etc., out of secondary care for some of the time and having them work in primary care, because number one, that is more efficient from a money point of view, and number two, it gives you a better service, and number three, it creates capacity in in secondary care for the work that only secondary care can do in a more timely fashion. Now, the other thing we haven't quite covered is manpower. So, do we have urologists or nurses, etc., who are able to do this work in primary care? And I think we do. So certainly from a consultant point of view, we do have capacity within job plans that is sometimes used for consultants working with universities and medical education, etc. But there is space there for some consultants to come and work in primary care. So we can better utilize the resource we have, the human resource we have. Yeah.
And just to add to that, I mean, one of our potential next steps, if we had carried on, would have been about, well, how do we add to our workforce within primary care for this type of work? So as we've done in other areas of long-term conditions, can we, train up more GPs with special interest in urology? Can we train up more specialist nurses in urology? The answer is, of course, we can. So again, it's that long-term thinking about, the collective workforce, a different type of workforce, all working on that sort of journey and pathway together. And I think, you know, they themselves would also enjoy that greater integration, seeing they themselves want to see that patient sooner and start that journey sooner. They themselves want to make sure that, a huge proportion of patients coming in aren't unnecessary because they don't want that either. So it is about those different stakeholders, which we know it's very difficult, but because we've worked in these, classic silos of funding and, workforce and pathways is where we're at. But there is a different way, and that's what we really need to try and look at.
Thank you both. We've got some time for some more questions. I just wanted to invite anyone else who's got a question to either come off mute and ask it or to put up your hand. So please feel free if there's other questions bubbling away.
I mean, the point that I'd just like to make while we're waiting is that Lord Darcy's review basically shown that the status quo is not sustainable, because basically what we've seen is, I hope I got my numbers right, but basically the amount of overall NHS budget going to secondary care has gone up from, is it 47% to 58%? Something like thereabouts, but actually productivity has gone down. So we're actually, in secondary care, we are doing less with more, which is clearly not something which the country can sustain moving forward. So I think not thinking of alternative or better ways of working it's not optional. I think it's mandatory. Yeah.
Yeah, one of the questions that we asked people to submit questions in advance of today's visit. And one of the questions that somebody asked was which might be a really hard one to answer, but what one change do you think made the biggest difference?
One each.
Yeah, all right. You get two, one each.
From my perspective, I think it was that change in relationship between all the staff involved. So that includes the primary care clinicians, the consultants, the healthcare assistants, the operational team, all working on that journey and that pathway together and feeling truly integrated. I mean, some of the terminology I've heard, like, there's people feeling liberated that they can actually try something really different, that feels different, is different, and is having that change.
Asad, what's your one thing?
I mean, for me, it's really focusing on quality. So I think it's a false economy to try and pack patients into a clinic, give them 5 minutes max, hardly speak to them, get them in and out, and just push them along, which often happens in secondary care. I'm very sorry to say. I've seen it throughout my career. Overbook clinics, poor communication, an unhappy patient who then goes to their GP and says, look, I was seen in hospital, but I don't really understand what happened. Here's a copy of a letter. I don't really understand the terminology. You know, I'm still no better off. And actually, if you give them that bit more time, allow them to speak, allow them to respond to what you've explained to them, make sure you check understanding, then that actually is better utilization, because it means the patient's not going to come back. He's not going to go back to the GP and take their time. He's not going to be unhappy and want a re-referral for a second opinion. I think that's really important. That sometimes it's a false economy to try and, you know, just add another 5 patients to your clinic because there is an outpatient waiting list for, you know, that's, I don't think it, you know, it's just, yeah.
I mean, that's a really good point. I said, in fact, just to build on that, even within our, obviously hospital, there is advice and guidance, which is great. However, I think from the work that we do, which is sort of equivalent, but we think slightly different in the special advice, the fact that it's within the patient record, done in a way that is much more integrated and, you know, probably more detailed in the time spent on that in that first step than a hospital would have a chance to do, which is understandable. Again, the bang for that buck down the pathway, you know, reaps its rewards. So, but this goes back to my point. We completely, and I hope this has come across, that we are not, you know, saying that anybody working in secondary care is not doing a great job, as they are, and working really hard. It's the system, the processes, the historical way of working that has led to this, that probably if they sat down with a blank page would not do that. In fact, I have done that with other consultants and said, look, you know, just to talk frankly with, you know, would you do this? Yes, we would do it if the system and the funding would allow us to do that. So, you know, they would want to do that differently too.
Thank you both. We've got one more question before we move into some breakouts. Christine's asking, how did you identify what clinical procedure or diagnostic was appropriate for primary care?
So
yeah, go for it.
I'll start with that and then I'll get Asad to join. So clearly, we don't want to, and as I said, we started off, if you recall, each layer of addition was done in a stepwise manner. So we made sure things were done correctly. So we would involve, obviously, the consultants involved and our primary care medical director. And also, we make sure we have the appropriate indemnity. And this is a really key important point, that we don't want a scenario where it's thought, well, we'll just take the funding from secondary care and we'll just put it into community. That's not the answer per se. It needs to be, the alternative still needs to be, you know, of very high quality, has all the appropriate indemnity required, has all the different assurances required, so that there's confidence from the whole system that this will also still work in a robust way as anywhere else that would. So that's that element. I mean, I said, in terms of anything else from the clinical side.
Yeah, I mean, I don't think we mentioned it, but basically the documentation is done on EMIS Web. So this is you know, the standard primary care, you know, electronic patient record. So really, within 24 hours, if that, you know, the referring GP has full access to what I've written, what I've found, the results of the investigations, the plan, and so on. So that's, you know, it's just increased integration between this clinic and the referring GP, speed of communication, etc. So that just helps.
Thank you. Thank you both. Thank you so much. I know a couple of you are heading off now. Thank you so much for coming. For everyone else, we've got a few minutes now. We're going to go back into breakout rooms. Just an opportunity for you to have some time with colleagues to think about what you're taking away from what you've heard from Mani and Asad, and what you might want to share with colleagues in your own context. A big part of these visits is about thinking about, how can I apply this learning in my context? What's kind of the relevance here? So let me pop a couple of those questions in the breakout rooms. So inviting you to share, what's your biggest takeaway from what you've heard, and what's one thing you want to share with colleagues in your own context? And again, we'll have just under 10 minutes for these discussions, and then we'll come back and hear some of those reflections before we close out the session. Welcome back, everyone. Thank you for that. It sounds like there might have been some questions bubbling away, so wanted to give some space for them to be asked. We've got probably about 5 minutes or so for questions for anything that came out of that before we hear about your reflections. Katie, was there some questions from your room for Manny? I wonder if anyone from that breakout room would like to come off mute and ask anything. Becky, go for it.
Hi, thanks. Yeah, it's two questions actually. The first one for Manny is how many PDSA cycles did they run during the pilot? And he mentioned that the pilot was soon coming to an end. And what's the next steps? How did they plan to take it forward?
Sure. So could be numbers that we didn't count, but there were definitely 4 phases of the change of the service, which was all about how far we went. So phase 1 definitely was, I think we got to maybe 20-30% of the activity within primary care. Then we got to 40-50, then we got to 60-70, then we got to 80-90. So I'd say 4 distinct phases that you could say, but as you know, there's so much that happens that is not formulated and discussed that you, as long as there's a principle that we, stay in the curiosity of we don't know what the answer is, and it may be good or bad, but we learn from it and move forward. I think that's the most important thing from our perspective, rather than it was 10, 20, 30, 40. So it was a second question, Becky.
Just now the pilot's coming to an end, how do you plan to move forward?
Yes, a really good question. So we've been talking to our commissioners, and they are looking into potential alternative ways of delivering this service, which is what we really wanted. So that's one. And the second one is obviously sharing with great people like yourself about what we've done elsewhere that hopefully might, bit of a catalyst for them to think differently.
Yep. Wonderful, thank you.
Thank you, Becky. I'd really love to hear any other questions or any reflections from those breakout rooms discussions. Were there any other questions that came up that you want to ask? Now's your chance. Or anything else that you're taking away from that, what you've heard from Manny and Assad today that you'd like to share? It'd be really lovely to hear from a couple more people. Ashley, go for it.
Yeah, I was going to ask one, Manny. Any type of change is hard, right? So I asked the question, how did you have any challenges with other stakeholders? Maybe not so much directly involved, but in other areas. It sounds like you might have done from the first thing I did, but it was just, so the question was really maybe then, like, how did you overcome those?
Yeah, I'm not saying we definite challenges and we didn't overcome all of them, but that's just how it is. I think I go back to the earlier point. A lot of this is about when we set it up, is about making sure that our own team internally was working on a philosophy approach, supporting them with the resilience, because you need that, because there'll be a lot of times when, we were, let's say, challenged quite robustly and we felt targeted, because it's like, we're just trying to do a good thing. But then what I kept on trying to make sure that myself and my own colleagues say, look, this is just a natural reaction to lots of different things that we probably don't know ourselves in detail from that individual or from that stakeholder, and how you can just stay in that, curious that what is making them say what they're saying, rather than jumping to our conclusions saying, oh gosh, how could you say that? How do you not know this is brilliant, etc., etc. So I think that makes a big difference, because when you start that in your own conversations, you are ready to act in that in a different way. And I think you don't have many goes at this, because when you speak to that new stakeholder, you don't want to lose them for a reason that just because the way that you might have approached something or said something. Does that kind of make sense?
Yeah, completely.
Thank you, Ashley. I'd love to hear what one thing you're taking from this that you want to share with colleagues. What's the thing that you're really, the kind of the golden nugget you're taking from this? I'd love to hear from maybe just a couple of people. What are you going to want to share with other people that you heard today? Would anyone like to kick us off?
I think listening to everything that both Manny and Asad have had to say and show us the slides, is although they've obviously specialised around urology, I think it can be taken in many different specialties. It could be replicated and adjusted.
I'm so happy that Becky said that, because the reason we chose urology was to show that actually this is a very traditional, difficult change area, and actually there's some others that are much easier that you could look at. And if you want to know of any of the ones that we've done already, Becky, do let me know. I'm more than happy to share those ones we've already done.
Just give them a quick shout out. What else? Yeah, what else have you done it with?
Yeah.
Oh gosh, diabetes, renal, MSK, mental health, the list goes on, because it's not rocket science, you know. It is a very simple but difficult but effective way of working, and a lot of it is about culture. We say that, and we know we hear that a lot, but it is that, and it is how you approach those things. And not all of them work. And to be fair, a lot of these, you know, we were doing respiratory for 2-3 years, Becky, and unfortunately it stopped recently because of politics and funding. We want to get it back. So yeah, it's a journey of a different way of working than just you know, lift and shift, as we've heard. But yeah.
And Steve, did you want to come in?
I was just going to add dermatology to the list.
Yes.
As if Manny could forget that.
Which is where it started, right? You were telling me that when everyone was in breakout rooms.
No, diabetes is where it started.
Diabetes was where it
Manny
started.
set that up.
Yeah.
Nice. Thank you so much, all. It feels like it's been a really useful and like inspiring visit in terms of thinking about how things could be done differently. So Manny and Asad, thank you so much for giving up your time and for sharing your expertise. We're just going to share one last thing before we close. In true quality improvement style, we'd really love to hear your feedback on today's visit. So you can either get out your phone now and scan the QR code that's on the screen and do it on your phone, or you can, Gweno's going to pop in the chat the link to the survey. So it's really helpful for us to hear what you're taking away from this visit, and any other feedback you've got about the visit. I'm curious to hear, what stands out. So I'll leave that up there. Massive thank you to Manny and Asad for your time, and a big thank you to all of you for dialing into this on a very hot Thursday afternoon. Gweno, Katie, anything else that either of you want to say before we close?
No, just other than a really massive thank you. And I'm just going to put in the sidebar how to join Q. So if you'd like to join us, great, thank you. Great minds think alike. But yes, it's been really, really interesting and so many brilliant questions. So thanks to everyone involved. Been really good.
Okay, can I just add a big thank you to everyone who took time out to join, because I know how busy everyone is. I mean, that's one of the key things that we're working on. But also, just to say it one more time, genuinely a huge thank you to Q Lab, you know, and Health Foundation and Kate and the team, because without it, we wouldn't be able anywhere near to try these very different things.
It's fantastic. Thanks, Manny. Yes, Manny, as I said, we'll share feedback with you so you hear what people are taking away from the visit and their reflections. And for everyone else, we'll send around the slides that Manny and Asad have shared today, so you'll also have a copy of them afterwards as well. Thank you so much, and look forward to seeing you all again soon.